cleaning things. The very end of the town hall, we have a few people that's going to talk, and then your questions will be at the end. Those of you on the phone, you will not be able to ask questions, but you can always email me questions, and my email was on the initial email with things going out. So we're going to go on and start right now. Thank you.
Hey, testing. Can everybody hear me? If you don't know me, I'm Glenn Mathis. I'm in charge of the Infectious Disease Division. There's Dr. Donovan back here who's in charge of infection control. And we're going to be, along with Bonnie Billich here from nursing, giving you sort of an overview of coronavirus and what we're doing here, and also giving you time to ask questions here at the end. This is obviously, you probably hadn't heard of coronaviruses 6 months ago, and even on the ID screen, we didn't talk about them all that much, but they really are viruses that obviously have come to the fore with this new potential outbreak, or ongoing outbreak pandemic. What I would first comment on is that normally these viruses are associated with just common everyday colds, upper respiratory infections. So, for example, you can see this list of numbers up here. These are different strains that actually circulate in the community and can cause colds. And I kind of joke about it, but a couple of years ago when we got a special testing system to do DNA testing for viruses, I kind of volunteered because I had a cold to kind of be the guinea pig and test it out, and I had a coronavirus. So I don't know if that gives me any immunity. I would like to think so, but the reality of it is that for a long time these things have circulated in the community. They are also sometimes animal pathogens. We'll comment on that. And they also, specific strains, it's like a big family of viruses, are associated with some very severe lung infections, something called SARS, severe acute respiratory disease, which was a problem particularly in Hong Kong and Asia about 15, 20 years ago, something called Middle East respiratory disease, which has caused in the Arabian Peninsula some serious pneumonia. And now this novel 2019 coronavirus, otherwise known as COVID-19. So these have been circulating. I'm a little bit of a microbiologist at heart, so I always like to include at least one slide. This is what we call an RNA virus. There's RNA and DNA, and you can see that yellow spikes, those proteins in the outer coat. When you look at it under an electron micrograph, it almost looks like the virus has a crown. Corona means sort of crown, and so that's how the virus got its name. And also to comment again on this issue of the seasonality of these viruses, if you look at the second row here, you can see that coronavirus circulates roughly between December and April. So these tend to be more winter viruses. And what happens around April or May is temperatures get a little bit hotter, it's a little bit more humid, and at that time, as a general rule, the typical run-of-the-mill coronaviruses kind of peter out in the population. And I think our hope is that could be what might happen with this virus, although we can't really predict it. And viruses can be quite unpredictable and sometimes show up at times of year that you least expect it. But in any event, that's our hope is that rather than having ongoing transmission for the next 6 months, we're going to see it taper off. Here, of course, is where it supposedly started in central China at this city named Wuhan. And this data here up in the table is really very out of date. Apologize for that. And at least the initial concern was that they had these live animal markets where people buy animals and for food or whatever, and the thought was at least some of the early cases were people that were seemingly associated with that specific market. On the other hand, not everybody had that exposure history, and it was clear that this virus was actually being seen in other cities in China probably several weeks before that. So while Wuhan was really the major focus, it may have been a place where the virus started, it's still a little bit unclear exactly where the first cases really emerged. Here in the United States, we can see that we've had over about 1,000 cases over the past several months. In Los Angeles County, 27 cases with one unfortunate mortality, a woman that had been traveling extensively in East Asia this past several weeks. Most of these cases are individuals that have traveled from someplace where they contracted coronavirus or they had acquired it maybe from a family member. So we haven't seen, at least at the moment, widespread transmission, but it's on our radar screen and we're looking for it. Here's this severe acute respiratory distress syndrome that we talked about that was a coronavirus. And this, I think, is kind of a model for kind of the bad coronavirus that we might expect if this is patients are brought into the hospital. In this particular situation, it was one individual that went from Guangdong to Hong Kong who exposed a number of people in a hotel there, and then those individuals traveled and sometimes brought the virus to other places. So, for example, there was this one fairly impressive outbreak that occurred just from one case in Toronto, and what happened there is that this patient's mother had been traveling from Hong Kong. She came down with the virus and subsequently transmitted to some family members, and then he got admitted. And then over the course of the next several weeks, there were numerous cases that occurred at the hospital, oftentimes among healthcare staff or visitors. And you can see what's important about this slide is with this arrow up here, little flag at the top there, is that once they implemented strict infection control techniques, the number of cases dropped off dramatically. So I think that that's an important message and good news for us, is that if we can get a head start, identify people early, and make sure that they're isolated, it'll make a big difference in terms of prevention of transmission. Where do these viruses come from? Most of them actually, coronaviruses, their original home seems to be in bats. And they may then transmit this virus to other animals, and somewhere along the way, people get involved. Usually some other animal that possibly we're handling or whatever. For example, in the SARS outbreak, it was these civet cats that were being sold in some of these markets that may have played a role in transmitting the virus. We're still a little bit unclear with the COVID-19. It does appear to be very similar genetically to these bat-associated viruses, but there may be some other animal. This is one animal called a pangolin that might have played a role, but it's really still, I think, very unclear. How is this transmitted? In infectious disease and epidemiology, we generally have a couple of ways that viruses and bacteria are transmitted. It could be by droplet, and that's where a person is speaking or coughing, and there's a droplet usually between over 100 micrometers, and this droplet travels about up to 6 feet. And I suppose if you're within 1 foot of that person and it hits you, in your eye or whatever, I suppose you could potentially come down with it. In this situation, a face mask would be effective, at least for prevention of spread to your mouth, but you would need goggles also to prevent anything from hitting your eye. Then there's a so-called airborne transmission, and that's for things like TB and measles, which are really quite infectious. And when people get infected with these things, they make very tiny particles that can float around in the air for a while. We suspect that there are some patients with this virus that are likely to produce airborne particles, particularly if they're being intubated or under a fairly intense sputum induction and things like that. Probably the average person sitting in the waiting room, even if they cough, it's probably not a major form of transmission, but it's something that we keep in mind, and it's one reason why we use these N95 masks. Then thirdly here would be contact. Somebody touches a surface, or you shake their hand, and then you touch your mouth or your eye, and that's why all these, recommendations to wash your hands are important. And then finally, there may be some excretion in the stool. I would also, here's basically a picture just showing how the surgical mask protects against droplets. The special N95 mask, or the so-called PAPR device, protects against aerosol spread. Just a brief slide here showing what happened in China in the first cohort of patients. These were sick people, with a significant mortality of about 15%. And I should say that clearly this is a sample of individuals who are sicker and admitted to the hospital. But if you were to look at large numbers of people out there, the vast majority of people are going to be minimally symptomatic or moderately ill. The patients that come down with severe disease are more likely to be older or people that are immunocompromised. Here's the first case that was seen in Los Angeles. This patient had traveled from China to Mexico City. He got sick there. He decided to get back on a plane, and at LAX, they identified him as potentially being a coronavirus patient, and he was cared for at a hospital on the west side for a couple of weeks. He had a sore throat, mild cough, fever, really hard to differentiate this from standard colds, in a sense. He ultimately was placed in isolation, and it turned out that, I think this is examination and some of the blood tests here, but he turned out to have a PCR, which is a genetic DNA test for this virus, and ultimately developed a pneumonia. And once he developed this, after about a week, they started him on like an experimental drug, and he actually improved, and ultimately came over here to Olive View because we have a very, very good isolation unit. They didn't want to send him out into the community until he had fully cleared the virus. But I can remember when he was brought over here, he actually looked pretty good, all things considered, despite what he had been through. Here are some of the stuff that we look for in the lab, and what we really want to do is, on these cases, as soon as possible, we get this special viral test kit here, the tube on the left. They do a nasopharyngeal swab. It's got to go deep in the back, and Dr. Donovan has a picture of that. Show you exactly how to do that. And then we send that off for influenza, and then if we're suspicious of the COVID-19, we all ask for that. We're getting now a turnaround time from the public health lab about 48 hours. Additional care here is really, for the most part, supportive care, making sure that they get oxygen if they're having trouble breathing, fluids, things of that nature. And then it turns out that there are a number, and this is, I think, a good piece of news here, is that there are a number of agents out there that in the test tube or in cell culture seem to have activity against this virus and could potentially be used as a treatment. So, for example, this drug Kaletra is something that we already use, already used for HIV, and we can potentially use that. There may be some activity of that drug here in these patients. And then this drug that our patient got here called remdesivir is now being tested in larger trials, and we would have a potential to get that if we identified any patient. So just one final slide or two here. These are people that we suspect, you might hear this term called PUI, and these are people under investigation, people that we think could have coronavirus, individuals with fever and cough, who have either traveled to an at-risk area, who have had contact with the patient, who have severe respiratory disease, or who have what we think is viral pneumonia on chest radiograph. And then this is what would happen if they arrived in the clinic or the ER. They would be immediately put in a private room or a separate area. You place a face mask on the patient. That minimizes the amount of spread. And then when you see them, you would wear a special mask. And then we would evaluate the patient, call infection control. And then if we had a high enough suspicion that this was a coronavirus patient, we would transfer them to our special airborne unit over on 2F, which is really quite a unique place. And my final comment here is, don't forget influenza. Of all the patients I've seen in the past 2 weeks where somebody said, gee, could this be coronavirus? Several actually turned out to have influenza. The first time I've been able to say to a patient, gee, I'm glad you have influenza, because we have a treatment for that immediately available. So in any event, that's it. Next person up here is Dr. Donovan, our Chief of Infection Control.
Thank you, Dr. Matheson. Isn't that fantastic? You get it's almost like clip notes of coronavirus. I feel like I'm always educated when I come to Glenn's talks. I want to thank Lee for coordinating on very short notice this informative discussion. We've limited attendance because of concerns for social distancing, which will probably become more stringent as things evolve in Los Angeles County. I know this is like the worst time for me to be talking because I'm talking about infection control, which many people find boring, except when there's an outbreak. And also it's 2:30 and Lee did not provide coffee, which I was very concerned about. But I'm glad you're all here, and I know most of you. And I think this is a very dynamic time for us, not only to all of you, but in Los Angeles and California. So we're in the middle of a pandemic. I believe it was a pandemic probably about 10 days ago. The last pandemic this hospital experienced was H1N1. Both Glenn and I were here during that pandemic. We actually diagnosed the first case of H1N1 during that pandemic, and we also had the first Los Angeles case here. So I think that's somewhat historical, and we also have the only biocontainment unit west of Nebraska, which is an infectious disease unit that has a lot of experience in dealing with communicable diseases. So we're very fortunate in Los Angeles that we have these resources here on site and the training that goes on these resources. All of you are very important ambassadors, not only here in the hospital, within your areas, but also out in the community. I think all of you know that there's been a tremendous amount of misinformation that's been spread about this particular epidemic. And as healthcare workers, what you say has a tremendous impact both to your colleagues, but also to your family, your friends, to your church. So I really want you to listen and take home what Dr. Matheson said, and I'm going to talk a little bit about how we can keep our healthcare workers safe and our patients safe, because healthcare worker safety is our #1 priority. If we don't have safe and healthy healthcare workers, we can't provide care to our patients. And I think that's really, we can't overemphasize that. And so I'm going to be talking about infection control, but we have 2.5 infection control providers in the hospital. And it's important to remember that all of you are infection control advocates, right? Infection control is everyone's job. So I'm going to do a little bit something different than what Dr. Matheson did. He gave you a little bit of a short lecture on coronavirus, but I'm going to talk a little bit about the infection control, and then I'm going to go over the 10 most common questions I've been asked since the beginning of this outbreak, not by the community, but by healthcare workers. The information on this epidemic and about COVID-19, which is what we're calling this coronavirus, is changing on a daily basis. So it's very important when you're in an epidemic or a pandemic that you're very flexible. I think this is like my 10th epidemic. It's my 3rd pandemic that I've been involved in my career. And flexibility is critical during this, because if we say, but you said 2 weeks ago this, but now you're saying something different, that's very typical for a novel or new pathogen. As this pathogen is in our community longer, we get more information, there's more science, there's more research, and we're going to adjust to what the data shows us, because we want to be data-driven and not fear-driven. And the reason I'm wearing this T-shirt, you'll see both Bonnie and I have it, is when I say keep calm, I'm not saying that this is, a minor disease, but just like coronavirus, fear and panic is contagious. And you're all healthcare workers. So we're really expecting healthcare workers to be leaders for everyone. The second thing my T-shirt says, if you can see it, and wash your hands. I get probably close to 100 emails and texts and people that find me on social media of what can I do. They think there's some magic pill. Just washing your hands will prevent most respiratory infections, or the majority of them. And we have noticed since the beginning of this outbreak that we are depleting our little alcohol hand washing stations. So I'm wondering, why aren't we doing this all the time? But as soon as we get an outbreak, people realize, right, from our patient safety, that hand hygiene is super important. So let me just get in this because Lee's going to start giving me a signal that I'm falling behind because I like to talk a lot. So what are some of the infection control challenges? I'm not talking about me, but for all of us, because this is all of our job. Well, the PPE, or personal protective equipment, and isolation guidelines are dynamic, they're evolving, and that's very confusing to healthcare workers, right? Sometimes it's confusing to me. So as of 11 o'clock last night, the isolation guidelines have changed that were issued by the CDC and by the state, and we're going to be updating those tonight. Why has that happened? Well, a couple reasons. One is we have more information. As Dr. Matheson said, it looks like this infection is primarily droplet-driven, except for a few situations where aerosols are created. And we're also in the setting where there's an overuse and abuse of PPEs. So we have national shortages. So all of you that are going out and buying up surgical masks or maybe taking masks home, this is impacting our ability to provide safe patient care. The shortages of PPEs we're addressing on a daily basis, doing inventory, making sure that we have enough for our staff. And this is something that doesn't just impact DHS, this is impacting UCLA, Cedars, community hospitals, hospitals in New York, all across the country. There's also shortages of tests nationally. So I'm sure all of you know that nationally, our public health response has been suboptimal at the best. So in other countries, there was a rapid deployment and extensive screening with tests. That did not happen in this country, which means that we already have community transmission with lack of containment. And that's why you see some areas like Seattle, where by the time they found out they had cases, all of a sudden they have 100 cases. Really, we want to stop transmission when we have a handful of cases. And then there's the concern of healthcare worker infections that has been seen internationally. And many of these infections are probably related to the lack of implementation of PPEs, for example, in Italy, where maybe they thought they were seeing flu cases and were not wearing PPEs and, unfortunately became infected. And then I have to say the confusing and contradictory information in the media has been very inflammatory. So Dr. Matheson went through the symptoms and the transmission and some of the prevention we're going to talk about, the hand hygiene, and then how do we protect people against the two main forms of transmission. It's going to be acquisition by the respiratory route and acquisition by your hands, by lack of hand hygiene. So what do we know? We know that the majority of transmission is droplets and fomites. And I think you put my old presentation. I sent you the updated one. And this is my old one, I can tell. It's okay. We'll deal with that, but I just noticed. And fomites is just a fancy way of saying surfaces. So if I cough on the surface and then you come by and touch it, you potentially then can touch your eye. It's not going to go through your skin. It's really mucosal involvement. So putting your hand in your mouth, your nose, your eyes. And I already see some people touching their nose in the audience. So this is very common and involuntary. It's very difficult to change behavior. So really attention to hand hygiene. Strict adherence to IPC measures, infection control measures, has clearly been shown. Dr. Matheson showed you a slide. It's already been shown in Japan, and I believe there was another study in Korea, to prevent healthcare worker transmission. Routine cleaning products are effective. We're actually using a higher level where we're doing enhanced disinfection and then increased disinfection of high-touch surfaces in the hospitals. And also important because there's been this concern about asymptomatic transmitters. The bulk of transmission in every infectious disease is from individuals that are symptomatic. So we know that this is primarily a droplet infection. So if we have, for example, Dr. Finley is here, a pediatric population who, for whatever reason, don't get really sick with this. There's been virtually a handful of cases that have been admitted. So young adults in the pediatric population are fairly spared. But they can be positive. They can be infected by their household members. Those individuals are not going to be driving in a significant transmission other than touching surfaces because, number one, their viral load, the amount of virus they have in their secretions is lower, but also they're not coughing. And to create droplets, you actually have to cough. So that's good news from that standpoint. And so that's why we're pretty clear that most transmission, like other infectious diseases, comes from the patients that are most symptomatic. That's seen in virtually every infectious disease is if you look at people with higher symptoms or viral load, the amount of virus they have, both in their blood and in their sputum, in their nasopharynx, increases. So common questions about COVID. Where do I find information for what to do in my area? So I'm going to have Lee put this on afterwards because it's not going to show up. It went blank, so I had to change the color of it. We'll show you when we're ready for questions. On the actual intranet, there are two links. One is a big coronavirus, like you've already seen Dr. Matheson showed you the virus with the crown around it. That links you to the entire DHS if you wanted to look at DHS-wide policies. Underneath that is a smaller link that says COVID-19. That's the olive view link that has all of our forms, our flow chart, how to collect specimens, and we update that on a daily basis. So we've heard what a PUI and a COVID case. What's the difference between that? How do I know someone is a PUI? And then what do I do about that? So PUI is a new term CDC came up with. It's a person under investigation. They meet criteria that they've traveled and they have a fever and cough. They're a close contact of a confirmed case and they have symptoms. They're a healthcare worker and they have symptoms. They're in the ICU with unexplained pneumonia, severe pneumonia. That may also be a PUI. That definition changes on a regular basis. 2 minutes. So a COVID-19 case is going to be someone that's been confirmed with a lab test. What is PPE? I think everyone here knows what PPE is. That is what we use to protect ourselves. I always like to show the older white doctor on this because I find they actually have done studies. I'm sorry, the older doctors here. They've done studies that the compliance with hand hygiene decreases with older male doctors. Just the facts, man. Just the facts. So this particular healthcare worker is kind of wearing all the possible PPEs you can. And so PPEs are just gloves, gowns, aprons. We all know this. Respirators, which actually can filter out those very, very small organisms, most commonly tuberculosis and measles. Some type of protection for your eyes and mucous membranes. That could be goggles or face shields. So what PPE you're going to use with COVID, and this is PPE that we used for a flea infestation in one of our buildings where it was full PPE. It's going to really be dependent on local and national guidelines, and it's going to be dynamic. So if it changes, it's not because we're changing our mind. It's based on national and California guidelines. Where to remove the PPE? It's the same, just like an MRSA patient. PPE goes off in the room before you leave, with the exception of a respirator. If you're wearing a surgical mask, it goes off inside the room. Respirators are disposed of after you leave the room. Most importantly, then you wash your hands. So another common question, I get this all year round, my coworker is coughing and I'm worried about getting sick. Should sick healthcare workers be working? We have an employee health policy on this. If someone has an acute illness, they need to go home, right? We know that there's going to be community transmission of COVID. We don't want that brought in to our institution. If they were exposed to someone who's a PUI or a COVID case, they should report their symptoms immediately to employee health. If there are exposures, we follow those individuals over a 2-week period, which is the incubation period. What are we doing to keep sick visitors and patients out of our hospital? And that's another slide that got dropped, and I added it back in. So I can tell you this verbally. What are we doing? So I think all of you have noticed that we're in phase 1 of our screening, at the entrance of the hospital. That just was implemented to start kind of more of a passive. Do you have a cough or fever? Here's a mask. The next phase is actually going to be severe visitor restriction into our hospital. The other ways that we can restrict it is calling patients before they come in, and if they're symptomatic, they don't come in. If they're significantly ill, they will be referred to the emergency room. And do you want to add anything, or are you going to talk about this a little bit? Yeah, you're going to talk a little bit more. I know I'm limited on time. And where do patients go when they get COVID? At the beginning, right now, they're going to go in two different places. If they're stable or need telemetry, they're going to go to 2F, which is our infectious disease unit. That unit has all negative pressure rooms. A lot of training has gone on in that unit. If they're at ICU level care, they're going to go to 5E South. That unit has been identified, and our pandemic plan is where we would put infected patients with pandemic strains. All those rooms are negative pressure, and that staff has also received extensive training. We already talked about that. How is the hospital and county preparing for this epidemic? As I said before, the number one priority is healthcare worker safety, followed by patient safety. There are regular meetings of the Olive View COVID group on a regular basis. There's also a daily meeting at the DHS level that we are all participating with. That meeting is generating county-wide recommendations so that we are standardized across the county at all of our county facilities, both inpatient and outpatient. It also provides a county-wide assessment of PPEs so they could be allocated across the county, and a core COVID group, which responded to that first patient, received extensive training and has been caring for the patients, and frankly has really enjoyed the experience. People actually want to get in that core group. And they've to date have taken care of one case successfully, and that patient has my cell number and still contacts me. We're kind of buddies now. And then we've had 3 PUIs now to date successfully. One that was an outpatient. And ongoing training is being provided to healthcare workers who may need to care for a patient. So I won't take questions now. We'll move on to Bonnie, and we'll save the questions until the end.
Hi, everybody. For those of you that don't know me, my name is Bonnie Village. I'm the Chief Nursing Officer here. I just want to dovetail on what both Dr. Donovan and Dr. Matheson have brought up, is the extensive training that has gone on over the past month or so with staff here, but then also discussions and collaboration with our partners across the entire DHS. This journey started for most of us over the 3-day weekend in February when we were asked by the Department of Public Health to accept the transfer of a known positive patient from an outside facility. And there was a lot of work that was done over those couple of days before we got the patient. And I'm very proud of the fact that we had the patient for a total of 7 days until he was cleared by the CDC and the Department of Public Health, and like Dr. Donovan said, was successfully transitioned back into the community. At that time, one of the major things that we did is that we limited the number of people that took care of that patient. And the reason for that is that we consider the safety of our employees at the highest level. And the limitation of the number of people taking care of that patient helps us. Because for every patient that has contact with a known COVID positive patient, we are expected by the CDC and the Department of Public Health to monitor that particular healthcare employee for a total of 14 days after their last exposure. And what that means is that we ask that healthcare worker to take their temperature twice a day and do a self-monitoring symptom check every day: cough, fever, shortness of breath. And then every day we have to, the organization needs to touch bases with that employee and make sure that they've not developed symptoms. I'm proud to say of the 8 people who took care of that patient, and we, over that whole 7 days, it was a total of 8 people because we clustered the care, all went through the surveillance period. None have developed symptoms, and are continuing to take care of other patients who are patients under investigation. As Dr. Donovan said, we have had a total of 3 PUIs that have been cared for on our 2F infectious disease unit. As of a little bit ago, the third one cleared. 2 of those 3 have been discharged, and this has been over a couple of weeks now. 2 of those 3 have been discharged. The last one is improving greatly. And I think that it is really due to the systems that we put into play that has been successful in having a low threshold for identifying persons under investigation and taking the precautions to make sure that our staff are safe. Have we learned a lot along the way? We certainly have. We consider ourselves fortunate to have been asked to take care of that first COVID patient because it gave us an opportunity to really get our procedures in place in a controlled situation because we knew this patient was coming in. We knew that this patient was positive. We had 2 days to plan and train staff, and we were successful. We've also had persons under investigation that have come through the emergency room, that have come through and not identified as patients under investigation until they've been on an inpatient ward, and then identified, and we successfully moved a couple of patients either from the emergency room into other units or from other units into the 2F area. This is one thing that I want to talk to you about in terms of keeping calm and wash your hands. Over the last couple of days, many of you may have seen it, people moving patients through the hospital with security and closing down elevators and such, and then our very responsive environmental services team coming and cleaning up after them. Now, what we have heard, remember when you were a kid and you played the game telephone? So Patty tells the next person something in their ear, and then it goes on and on and on. And by the time it gets around all the way over to Dr. Gibbons over here, it's a completely different story. So what ends up happening is when people see things like this going along, they say, oh, maybe that's a COVID patient, a corona patient. And then the next person, oh, there was a corona patient in the elevator. And the next person that gets it, oh, there's corona patients all over the hospital. Okay? When you see that happening, it's a big hullabaloo because we want to make sure that we clear the hallways. If you recall, we want people to be 6 feet away, so we don't want people that are waiting for the elevator to be standing right next to a patient that's a person under investigation. We want to minimize that risk. Why do we clean? Why do we have environmental services clean? Because they've been in the elevator. It's a closed space. And we want to make sure that it's clean and it's disinfected so that our staff can continue to use that elevator. So it's not something to get overly concerned about because we are using all of the requirements and the recommended processes. And just because you see somebody moving in that fashion, please do not assume that that patient is already a person of interest or a corona-positive patient. We did a move yesterday from the ED up into the ICU. That patient was never a person under investigation. We had some questions about it, so we took the highest precautions, but they were not even labeled as a person under investigation. So when you are talking to your peers up in your areas and they say, what did you hear in the town hall? I'd encourage you to share a lot of the things that you've learned in order to reduce the anxiety. We don't want you to be laissez-faire about this. We don't want you to go to the other extreme of not caring. We want you to be like right in the middle where you are alert and you know what is expected of you and that you can respond appropriately. It's all about situational awareness and making sure that you are implementing all of the most up-to-date recommendations that are coming. What do you do if you have a question? Well, there's a couple of things. Number one is if you go to the All of You website on the internet, you'll see a big coronavirus, right? You see that? You click on that, and that's going to take you to the Department of Health Services webpage. A lot of very, very good, important information. And then there's a little blue rectangle right underneath that. We wanted ours to be the bigger one that, DHS has bought, so we had to let them have the pretty icon. But we have a little blue link down there, and that's to the All of You website, which has our current guidelines and policies. And as Dr. Donovan said, we're going to be updating that this afternoon or later this evening because the requirements that are coming out of the CDC and the Department of Public Health have changed. And we want to be up to date, and we want to be able to use the most recent and most current recommendations. I just want to say a couple of words about PPE. Today there was a blast email that went out about redonning N95 masks. So you know that there's our surgical procedural masks, and then we have the N95 respirators. We now are following the CDC guidelines that allow healthcare workers, when the patient warrants a N95 mask, to reuse that mask 5 times under certain conditions. And I encourage you, any of you that have exposure, have the opportunity, have the experience, work in areas where you may need to use an N95 mask, that you familiarize yourself with that process. Because we want to be good stewards of the available resources. Just like we've previously talked about here, is that if we all use the highest end personnel protective equipment and we deplete it, then if we get somebody that we really do need to have that equipment for and we don't have it, then we're exposing our coworkers unnecessarily. So please be good stewards of the PPE. Please only use what you're going to use, but you only use and take what you need at that particular time. Please do not hoard or feel like you've got to get the last packet of toilet paper on their Costco. Because someone else who may need it more than you. And so with that, I'm going to, do I have more time?
Well, you have time, Bonnie. You have 6 minutes.
Oh my gosh, okay. What are we going to talk about next? One of the, Dr. Donovan mentioned it, is that what are we doing to reduce the risk of transmission between patients, visitors, and staff? We did start preliminary screening, and the patients coming in on the first and second floor are being asked just very simple questions about have they traveled, have they been exposed to someone with the coronavirus. And in addition, they're asked if they have cough, fever, or difficulty breathing. And they are being given 1 surgical mask to use during their visit with us. I had a meeting earlier this afternoon where we are looking to do some increased medical screening at the doors. So if a person, after answering those questions, needs a mask and they are a patient, then they will go to a secondary screening. And in that screening, there'll be a more in-depth discussion with the patient, some additional questions, and make a determination if it would be more appropriate for that patient to reschedule at another time. It's okay to go to that clinic appointment or that diagnostic treatment, or we feel that this patient needs a level of care because let's say they're short of breath and let's say their oxygen saturation is low. We really don't want them to go to clinic. We want them to go to an appropriate place. We're yet to determine where that appropriate place is going to be because we want to put the right patient at the right place at the right time. We are going to be limiting visitors. So there is a DHS policy coming out later on today that is going to restrict visitation to patients under only very specific circumstances. And in those circumstances, the patient may only have maybe 1 or possibly 2 visitors come into the hospital. And it's not only 2 visitors at a time, it's 2 visitors, period. Because we cannot continue to expose our public to situations where they may become sick, and we certainly don't want our patients or our staff, our healthcare workers, to be unnecessarily exposed. Okay. I also do want to reiterate the fact that, oftentimes we feel like we have to come to work because there's nobody else to take care of the patient. But if you're sick, you may not have, COVID. You may not be a person under investigation, but you're obviously sick and you're going to be more vulnerable to catch whatever it is. It's going to be the flu that's running around, coronavirus, some bacterial kind of a thing. So please take the time to go home and rest. We are laxing some of our attendance policies in terms of having to have a medical certification under certain circumstances, because we realize that, again, we don't want to add to the problem. If you are sick and you just need to stay home, why do we want you to go to the doctor to sit in the waiting room with a bunch of other sick people and possibly get each other sick again just to get a doctor's note? So we have made some changes, some temporary changes through the situation that we're in now. All of these things, really, if you have questions or need to know about, either go to the website or ask your supervisor. If your supervisor doesn't know, go up your chain of command. Things are changing really rapidly, things are fluid, and we want you to get answers to the questions that you have. And we want to have the same answer to the same question as we move along. Don't you just love it, like you call the IRS or somebody, you talk to one person, they tell you one thing, and another person, same question, they tell you something else. We want to control that so that you get the most accurate information and that we develop trust among each other, that we're all looking out for one another. I think I've time, and I'm going to turn it over to Mr. Dunn.
All right. So now we have time for questions. We have 15 minutes for questions, as you can see on the time bully. We also have employee health care, supplies. EVS was here earlier than I hear. We have infection control, so please feel free to ask your questions. If we don't get to your questions, you can put your questions on this board here, and we will kind of circulate those out at probably tomorrow to answer those questions. So please have at it. Any questions? Yes.
Thank you, Sabina, for bringing that up. It's kind of a corollary with the fact that, the looky-loos and the fact that we are cohorting these patients onto F5B South. Patient privacy, the restrictions and the requirements of HIPAA mean that you are only to access the medical record or ask about a patient if you have a business reason to know. So please don't go into ORCID and take a look at and open every record on 2F to try to find the person under investigation or whatever. Please, please, please. You're going to get into trouble, and you don't need trouble, okay? And the other thing is that these patients deserve to have their privacy. It's really, really important. Please don't continue perpetrating gossip, because it's not good for the patients either. We have this patient in-house, and I call it the worst kept secret in all of your history. But come to find out, somebody said, oh, I didn't know that, and they were here at work. So please, we're trying to keep this as respectful as possible with all of our patients. So please protect their privacy.
Wow, you guys were a quiet group. Yeah.
My dog.
Well, if you go to People Magazine, in Spanish, I'm interviewed on that. So dogs can, at least, they can get lots of moving memories. There's even a form of whooping cough that dogs can get. But dogs can get colonized, at least there's been anecdotal reports with coronavirus. And they don't knowingly transmit it. I have a funny story. When I was in Sierra Leone and I worked in this very busy Ebola unit, there were dogs and all kinds of wild animals running into the unit. I wanted to test them all for Ebola because I thought, God, I wonder if they all have Ebola. And that's one of the transmission routes here. But I don't believe that domestic animals are a driver of this. However, if I were to get colonized by my dog's outside, and I do have a pig, so I worry about my pig.
What medication do you have available?
We have no medication. No medication is approved. However, remdesivir, I sent what's called the IND as an investigation drug application. The pharmacy, that drug is made by Gilead. It was developed for Ebola. We continue successfully with clinical improvement in a number of patients. I believe Gilead is probably going to limit its use because there's so many cases in the United States. There's some limited data. I believe Dr. Matheson listed all the metachloroquine and HIV protease inhibitors have been used as in combination. In China, they would put people on thinking and maybe not such a good idea. There's no data for ribavirin. The data on steroids is the WHO currently recommends that not to use them to make prolonged shedding. But if you look at the first 15 U.S. patients, and that publication is going to be coming out soon, where I reviewed it, there was not prolonged shedding in the patients that were on steroids. So I've told the critical care people, you should follow your ARDS kind of guidelines and talk to your colleagues about this. So if we have 4 groups, there you are. But again, this is all loose data, and I think it's going to be on a case by case. It's supportive care. This is basically people who have pneumonia and they need support. Many of them develop cardiac complications, and so we need attention to that. But as Dr. alluded to, the vast majority of patients get a cold. And so when you hear the case fatality rate, which is the number of people who die over the number of people that are infected, what's been reported in the literature is 4%, anywhere between 2 to 4%. So in other words, 2 individuals out of 100 or 4 individuals out of 100 will die if they get this. That is not accurate, because what they're doing is they're only screening what the data is based on individuals that get admitted to the hospital, are sick enough to get admitted to the hospital. So it's the tip of the iceberg. So I would agree, if you're really sick and you get admitted to the hospital, you have a high chance of not doing well in a country that may have limited resources, right? If you screen everybody, which we have not done in this country, that case fatality rate will drop dramatically. And in fact, Korea did a fantastic job of screening people in drive-in. Lower the window, you do the swab, and their case fatality rate was about, I believe, 24%, with the drive-ins for people, a mixture of mild but more severe symptoms. You could see the difference if you actually expand the surveillance. We have not done that in this country, so we don't have the data, but we can extrapolate.
Well, one other question is, Cindy, what about, what about my children at home? I think the good news is that generally children tolerate this virus quite well. So the need to
yeah. Is there any discussion yet about increasing elective visits or operations?
There have been discussions of that at the DHS level, and when we get to that point, those decisions will be made at the DHS level because we're looking at it as a system. What we've done is we have one of our sub work groups from our All of You Novel Infectious Disease Preparedness Group is the ambulatory care setting, and we are looking at the possibility of reducing primary care visits that can be rescheduled. And much of that is because we just don't want people to come in and acquire or expose people to the disease. I think where we end up getting into another area that's a little bit more difficult is with specialty care. A lot of our patients have waited a long, long time to get into a specialty care appointment. We don't want to unnecessarily cancel those. I think Dr. Donovan mentioned making phone calls preemptively the day before and seeing if people have and have symptoms and then encouraging them maybe to stay home. Right now there's a blood shortage, and so elective surgeries, we're considering maybe affecting those. But again, we are going to take our decisions so we work as a system. And as Dr. Donovan said, we have a phone call at 9 a.m. every single morning, 7 days a week, to get the most up-to-date information from DHS, but then also DHS, we have a round robin, and we all report what's happening in our facilities. And outside of that 9 o'clock call, there are different work groups at the DHS level that meet in between to resolve some of these issues. So at the present time, no, but when we get to that point, those decisions will be made. There was another hand back here.
Yeah, it's following up on that. I am outpatient consultant. Should I be trying to convert to telephone appointments if I come across a patient that's asymptomatic?
That's another technique that we're using to reduce patients coming to the hospital. Primary care is a little bit more, and by extension, nutrition. Already have templates set up for telephone visits, and we're trying to transition to doing more telephone visits. So for those very same reasons. We do have an algorithm that we're working with in conjunction with the screening at the front entrances. It's called Ask and Mask, so that patients, as they are coming in, are asked these questions. If they get through the screening at the doors, that when they present to register, that they're asked again and given a mask. We're now moving into a time where if a person has symptoms, cough, fever, difficulty breathing, the protection, the PPE is to put a mask on the patient. If a healthcare worker feels more comfortable having a mask themselves, that's okay, except that really what you're doing by putting a mask on the patient is you're containing the person that has the symptoms. Adding another mask is not always necessary, and in fact, it depletes our supply. So when those new recommendations come out, either today, this afternoon, or this evening, tomorrow, then we encourage you to use those to guide your practice.
And I just want to add on that. So what CDC Public Health has done is we've escalated the intensity of with patients that are the highest risk, which is our cases that are admitted to the hospital. Very similar recommendations with suspected patients in the hospital and outpatients. We're going to be going statewide to surgical masks, mucous membrane protection, and so on. If you are seeing someone that might be a PUI, the patient can put on a mask and you can put on a mask. If that person is going to be considered a suspected PUI. And all of this is going to come out in an algorithm. It's all going to be adopted countywide. It's also going to be, I've already contacted all of our private large hospitals, and they are all moving in that direction. So part of infection control, which is sometimes easy, is we do a risk. The risk assessment is, well, you don't want to treat every patient the same, right? All the time. So particularly when we have limited resources. And so ambulatory patients are always going to be less of a risk than someone who's on a ventilator, that they're, that's potentially aerosolizing or high flow oxygen or giving enough treatment. I know it's confusing, and I think there'll probably be more to come on it, but no, that should go up tonight.
Susan, when you see these pictures coming out of places, you see it looks like they're a space suit. We've got these pampers that we use in the meeting. Are these really, just really necessary?
So for those of you that have worked in the infectious disease unit, we're a little bit of a capper unit because we get very drug-resistant cases there. There's no data that a capper is safer than an N95 mask. What the capper does is it combines your face protection and it's also a respirator. And in the setting of a mask shortage, it's a good way to conserve our masks. The other thing with the cappers is there is a recommendation by the state that if you're going to do high-risk diseases, which would be intubation, respiratory therapy treatment, bronchoscopy, things like that where you create aerosols, and another one would be hypoxygen, that you err on the side of using a higher level of protection. That's only for California. We're very lucky that we have a lot of cappers. Most hospitals do not. And so they will use N95. To answer your question about the Tyvek suit and all that, that is totally unnecessary. It's not recommended by WHO. I'm not quite sure. One of my mentees is in Kathmandu, and they only have one case there, and he posted a picture of 15 people fully gowned up, and he said, at ground zero in Kathmandu, and I let him have it. I said, well, what ground zero are you at? You have one case that was low risk, was sent home, and you look like you're going into the Ebola unit. So, anyway, if you went to my infection control lecture.
Okay. Last question.
So, let's say has like come into the social work office and has been asked the questions, but we ask them again and we get a different answer, what do we do?
Well, first off, what you want to do is you want to mask the patient.
Right.
Okay, so
We got that part down.
you got that part down.
Mm-hmm.
The next thing really is, does this patient need to have some sort of a medical evaluation? And actually, the meeting that we were talking about, I was talking about earlier, is if we have this two-step process to screen, then we would be able to ask those medical questions and make a determination what would be the most appropriate next step for that patient. If all else fails, and I'm really, is anybody here from the emergency room? Oh, good, I'm free. We really don't want to send people to the emergency room unnecessarily, because if they're, the walking sick, they're going to sit with a mask in the emergency room, waiting. If someone is, wants to see a doctor about their symptoms, and they can go to the urgent care, or they can go home and make an appointment to see their doctor if they're fine. In terms of staff feeling protected, again, if staff is more comfortable putting on a surgical mask in that situation where somebody is coughing a lot, that's fine, but the biggest protection you're going to get is if that patient has a mask. And then, what does it say at the bottom of my shirt? Wash your hands.
Yeah.
Okay.
I want to say something on services like social work and all that. I think you guys should strategically need to think about what is it that you need for patients to come in your area. And this be done with phone call services, because really I know your area, to have like a bunch of patients in there potentially coughing, or you're not sure what's going on and asking them. This is not a clinical, you're not providing clinical services. Can you provide a lot of your services over the phone?
We can, and that's what we'd like to do, but we do have walk-ins that just show up. And
right.
So those would be the people that I would be more concerned about.
So what I would do if I was in your situation, and again, you need to strategize with your department, is if someone is symptomatic, it's, are you sick enough that you need to go to the ER, or here's the phone number to call, we'll set up a phone appointment. I agree with you. I don't think they should be sitting in an enclosed office, like your office, talking away. There's something that can be done by the phone.
All right, thank you. If you have any additional questions, you can put those questions here, and thank you for coming. We appreciate it. Thank you, everyone on the phone, for calling in.